The title of the session that I'm leading is Learn, Lean, Lead, Ensuring Health Opportunities Through Purposeful Partnerships. And it's a tall task, the reason that we're all convened today to talk about aiming to address a lot of the challenges in our communities that impact health. And this is work that I've seen from a lot of different angles over the years and from a lot of different communities. Now, I'm going to get something out of the way now because I just said over the years, and I see some naysayers looking at me like, this guy's 12. I'm not. I'm older than I look. Where I'm from, we say black don't crack, so that's the reason why I look so young. However, it's important because, in the last few years, I've really spent a lot of time going all over the country working on these issues of equity and justice. That's what led me to get my law degree. That's what I'm passionate about, is trying to find ways to work. And so when I say health equity, I'll define that for you guys in a little while. You see in the title slide here, we talk about health opportunity. We're talking about the same thing here. And that's what we'll be focusing on today. So learn, lean, and lead. That's the recipe for success. We always have setbacks. We always have challenges, and we have to learn from them. That's so important. We have to learn to lean on the people around us in order to be effective. We have to partner well. And ultimately, we have to lead. Similar to how the UVA basketball team did last night, right? First number 1 seed ever to lose to a 16 seed. What a setback, right? And so what's the learning opportunity they had? They had to lean on each other throughout this tournament, and ultimately it led to a victory over this guy's team. I've sprinkled in several jabs at Texas Tech fans, so sorry, not sorry. So we'll go ahead and get started, and I want to kick this off by talking about understanding the challenge, this challenge of health equity. And there's a lot of ways to unpack this. So when I say barriers or challenges to health equity, the first question is, what is this goal of health equity anyway? What are we striving to accomplish? Or moreover, how are we defining this? Depending on your sector, if I say equity, you're thinking of something completely different. And so what are we talking about? I'll start with the World Health Organization. We'll start global. So WHO, they say equity is the absence of avoidable, unfair, and remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other means of stratification. Now they go on to say health equity, or equity in health, implies that ideally everyone should have a fair opportunity to attain their full health potential, and that no one should be disadvantaged from achieving this potential. And when you start off hearing this description, the absence of avoidable, unfair, or remediable differences, it seems really abstract, but ultimately it ends with a flourish. It ends with saying something that most of us can agree on, and that's that everyone should have a fair opportunity to attain their full health potential. What is one's full health potential, right? And in the pre-summit session, I just talked a little bit about the idea of genes and biology and the impact that has on healthcare, but we did the Human Genome Project. We know that genes don't determine all of your health. We know that healthcare doesn't determine all of your health, and we know that somewhere between 30 and 60% of your health outcomes, whether it's morbidity or mortality, is determined by these social, economic, and behavioral factors that really live in the places where we're born, grow, live, learn, eat, play, and pray. That's where health happens. And so allowing people to have the full opportunity to attain their full health, or the fair opportunity to attain their full health potential, that's important. So that's WHO. That's something that we're seeing all over the world, people are ascribing to, and is really taking flight in a lot of nations. Let's get a little closer to home. We'll use Healthy People 2020. 2020 is right around the corner, so Healthy People 2030 is coming out anytime now. But even still, the goals of Healthy People 2020 included some work in health equity. They defined health equity as the attainment of the highest level of health for all people. Sounds pretty lofty. the idea of the highest level of health, but that's one's highest level of health. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. That's how we saw it when we shaped Healthy People 2020. There are a couple of value statements in here that I want to really focus in on for a second. Valuing everyone equally. I think we can all agree that's something that we're comfortable doing. We're comfortable saying, look, I value everybody in my community. Right? I think that's a fair assertion. And saying that there are avoidable inequalities. That gives you some momentum, because you start to say these inequalities that we're seeing in education or transportation or income inequality or the food environment, these are things that are avoidable. We don't have to have these circumstances, and we know that they impact health. And so we have a little bit of momentum when we call these things avoidable. The idea of historical and contemporary injustices, that's important, because it's a lot easier for us to describe historical injustices. It's a lot harder for us to take that hard, long look in the mirror and say, what are today's injustices? What will our children and their children be talking about that we stood idly by and allowed to continue to ravage our communities? What are those things? Let's look at them now and let's address them. And then ultimately eliminating health and healthcare disparities. I always say health and healthcare disparities, those are the metrics by which equity is measured. If we see that there are differences in diabetes rates or heart attacks or cancer mortality, what we're able to say is that, yes, those differences exist, but why? And that's where health equity comes in. That's where those social determinants of health come in. They're a key part of the answer to that question. CDC, another definition. Health equity is achieved. Now we're getting to what does it actually look like? It's achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. You know, in the world of health disparities, we talk a lot about race and ethnicity. That's where a lot of the research on health disparities has been done. And we know that race is a social construct, right? But there are a lot of other socially determined circumstances that we're talking about. Poverty can be a socially determined circumstance. Low educational attainment can be a socially determined circumstance. And if these are the factors that are driving negative health outcomes, how do we address those? So I think this is where CDC takes that hard line and says, we want to achieve health equity. It's not just notional, but it's something that we can get to. And finally, RWJ, my fave, love RWJ. They say health equity means that everyone has a fair and just opportunity to be as healthy as possible. It requires removing obstacles to health, such as poverty, discrimination and their consequences, including powerlessness and a lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And so RWJ goes a step farther. They start to tell you what obstacles in particular we need to be addressing. For those of you who were in the pre-summit session, you watched as I walked through the 5 different domains of social determinants. And they're saying these are the spaces that we need to work in to achieve health equity. Fair and just opportunity to be as healthy as possible. That seems like a reasonable goal. I think just in terms of level setting, I think we can all say health equity, by these definitions, sounds like something we should be aiming for. Would you agree? I just asked you that so I can cough. It's fine, it's fine. All right. So that's the first. What are we talking about? That's the definition of health equity that we want to use. Next, the second challenge, are we compatible partners? Across the room, hearing Dr. Pate speak, there's so many different people represented, and as I was hearing him list off, I said, oh, we're going to solve this problem this afternoon. Everybody we need is at these tables, right? Are we compatible partners? Raise your hand if you've been in a partnership, I'm not talking about your marriages, that were not compatible. Right. It's hard sometimes to work with people, to work with groups where you're just like, actually, we're not aligned, and it's really hard for us to work together. And what I would say is that health systems often are hard partners to work with for a lot of reasons. A couple of different health system motivations that I want to describe for you. First is mission. What is the mission of the health system, and how do they articulate that? Second is financial incentives. Some of you are like, that was first. But financial incentives are big. You know, I remember when I was in law school doing a visit up in Detroit and talking to health system leadership there, and someone made the statement, no margin, no mission. Have you guys ever heard that before? That it doesn't matter how nice your mission is in terms of helping people around your region. Without money, without making money and being profitable as a health system, you can't do any of that stuff. So these are really, really connected. Third is the regulatory environment. You know, the Affordable Care Act passed 2010, 9 years ago, just a couple weeks back. And with that law passing, the regulatory environment changed. It changed. It changed what people were focused on. You fast forward, and Dr. Pate talked a lot about the work, talked about a lot of the work in moving toward value. But the regulatory environment helped push people toward working toward value instead of just fee for service. Those are things that policies help shape. They help move us along into that direction. And I'd say St. Luke's has adopted that more than a lot of other places. So what's that regulatory environment? And then you fast forward with the election of President Trump and this administration, the regulatory environment shifted again. How does that impact what the health system's motivations are at different points of time? And so keeping those things in mind, that's going to help you get a sense of, are they a good partner for me? Where are they in their motivations? I'll give you an example from my health system. The mission is to provide excellence, innovation, and superlative quality in the care of patients, the training of health professionals, and the creation and sharing of health knowledge within a culture that promotes equity, diversity, and inclusiveness. Raise your hand if you've ever had to write a mission statement. Could you just hear the arguments in that room as they were just like debating, oh, it add this and add that. It's this like weird transformer amalgamation of all the things we want to accomplish. The mission statement gives you a little bit of information, but you don't know anything about this health system just by reading this. I'll use yours because it's actually much better than ours. How we define health depends on each individual. Fast forward, St. Luke's is dedicated to our mission to improve the health of people in the communities we serve. To improve the health of people in the communities we serve. That's a pretty straightforward goal. That's what we want to do. There's a lot of nuance to that. How do we get there? But that's what our mission is. That's a good, clean mission statement. I'm going to take these slides back to UVA and be like, see, guys? But that means, and they go on, that means not only treating you when you're sick or hurt, but helping you to be as healthy as possible. As healthy as possible. You're seeing echoes of those equity statements that I just had up on the slides, right? To help you be as healthy as possible. And so we're going back to those definitions. What are the things that make it so that people aren't able to be healthy? And so that's your signal, community partners. That's your opportunity. That's your window. That's how you know, hey, this is a place where we can partner, where we can do work. We want you to look beyond your illness or injury and picture where you'll be on your health journey. We want you to picture your health. And that's a beautiful background. It's like rolling hills, and we want you to be standing in rolling hills, you know, cuddling with a loved one, right? That's the idea, but ultimately we have to address all those factors that are impediments to your health or well-being. The third question is one that's kind of been lingering in the air throughout. Is health equity attainable? Can we get there? Show of hands, can we get there? Can we achieve health equity? I really appreciate the honesty in the room because it's such a big problem. I understand why a lot of hands didn't go up. I mean, there's always going to be, you know, Johnny Glass half full, who's going to be like, yeah, we can. We can do everything and anything we put our mind to. Why? Because my mom told me so. But this is a hard challenge. This is as recalcitrant as any problem we have in our society. This is actually combining all of the challenges in our society in one space, right? Economic stability, education, health and healthcare, neighborhood and built environment, social and community context. Those are all the factors that impact health. And our job, in order to achieve health equity, is to address them all. So if your hand didn't go up, no judgment. I understand why. But I want to throw something else your way. So if we're looking at these definitions, health equity means everyone. That's all the people. That's all of the communities, all the demographics, all the geographies. That's urban, that's rural, that's old, that's young, that's black, white, Native American. That's everybody. So what does that mean? A fair and just opportunity. Fair opportunity to be as healthy as possible. Then, and I'm bolding these words and putting the underlines because these are the words that would make me hesitate to put my hand up a little bit, all right? Requires removing obstacles like poverty. That's an easy problem to solve. Discrimination, cakewalk. Their consequences, powerlessness, lack of access to good jobs. Jobs, we can take care of that. It's easy. Quality education, housing, safety, healthcare. That's kind of overwhelming. It's overwhelming for any one organization. It's overwhelming for any one leader. But it kind of feels a little like pie in the sky, right? A little like pie in the sky. This actually, pie in the sky, that phrase, do you guys know where it came from? I'm a complete etymology nerd. If I hear a phrase like, have you guys heard happy as a clam? Are clams happy? I don't know that they are, because we are usually eating them. So happy as a clam, the phrase was originally happy as a clam in high tide because nobody's getting to the clams, right? All right, so I'm always interested by that. Pie in the Sky came from a song this guy John Hill was writing. And it was, I think this song was called Preachers and Slaves. But in the song, he was really decrying the Salvation Army. And he was saying, you know, they're sitting here promising that everybody can have everything through salvation, when really they should be focused on like the real everyday problems of Americans. And so it was a line in the song that he wrote. So there. If you learned nothing from me today, you learned that A, UVA has the best basketball team ever, and B, you now know where pie in the sky came from. Okay. Another better question, what does our community need from us? So in all of this work, we've defined health equity, sure, but ultimately, like, what does our community even need from us if our job is to serve them? You know, I pulled up the Community Health Needs Assessment. This is the 2016 version. I know that 2019 is on its way, but these community health needs assessments are really important because they're a way that health systems try to identify what the community needs from them. And just looking at, beyond all of the healthcare, the health outcomes that we see, is also the different factors that are issues in the community. And you see we're up to page 105 where we're starting this. So these are lengthy reports. Education, unemployment, children in poverty, inadequate social support, single-parent households, violent crime. Then the physical environment, air pollution, drinking water violations, severe housing problems, driving alone to work, long commutes. These are issues in the community that need to be addressed for the community's health needs, right? And this is what's been identified. And there's a whole process that goes into this. These community health needs needs assessments, they're tied to the Affordable Care Act because it was one of the requirements for that nonprofit status for health systems. So if a hospital is going to fill out that 990 form and say, I'm tax exempt and I should be, they have to go through this process every couple of years where they're looking to the community and they're saying, hey, what do you need from us? It's a very exhaustive process. And in my community, we actually do ours together. There's 2 health systems, and we do it with the health district. And we have one big, happy community health needs assessment. But this is critical work. It helps give us one sense of what the community needs. But raise your hand if, as I went through this list, something else came to mind. That's not on the list. A couple people, right? And why is that? It's because you guys are working in spaces in the community where you're seeing problems from a different angle, or you're seeing other challenges. And so one of the critical parts of this is that this assessment is made by making sure that people are at the table. In the nonprofit space, where I spend a lot of time, people always say, if you're not at the table, then you're on the menu, right? It's one of those statements. But the reality is, this requires making sure that all those partners, that everybody's at the table. And it's a really hard thing to do, to get all the voices, all the populations, all the geographies, everybody in one space. It's a really hard thing to do, so we're still not able to cover all the ground, despite our best efforts. So that's where your voice becomes so important, and you have to understand there are always additional opportunities to partner, to jump in, to find spaces. And the next question is, and these are the better questions, right? So just going back, I told you, first better question is, what does our community need from us? The second better question is, can we afford to not pursue health equity? Let's think about the null hypothesis, as we call it. If we do nothing, what happens? I mean, this is a really terrifyingly enormous task. If we don't do it, can we sustain? No. No hesitation, I promise you. I promise you. There's no way that health systems can continue to operate, that communities can continue to thrive without us addressing these issues, right? We are at that point. The tension is so high. There's no way without starting to address these issues. Our costs in healthcare, $3.8 trillion that we're spending on healthcare, and it's not because that's how much healthcare costs. It's because we're terribly inefficient. We have so much inequity. When I said $3.8 trillion, I'll give you guys another one. So, because a trillion sounds like a number that we're used to because we live in America and we say trillion all the time, and we think that's normal. So let's see. 1 million seconds ago was 12 days ago. That's 1 million seconds. 1 billion seconds ago was 30 years ago. 1 trillion seconds ago was 30,000 BC. It's 1 trillion seconds ago. $3.8 trillion on healthcare. Right now, projections by 2026 is going to be $5.6 trillion. So yes, this is unfathomable. This is not workable. Oh, we can fix it. Medicare for all, right? Estimates are that's going to cost $32 trillion. Or I'll just say like 30,000 BCs, right? Ridiculous amounts of money. The answer is not spend more money. It's never going to be the answer. It's fix the inefficiencies. It's understand why our system is so flawed. And one of the reasons, one of the big reasons, is equity. Why did the United States have quality that was 37th the last time the World Health Organization did the rankings? Or when we look at other OECD nations, why are we always at the bottom in quality? The answer is equity. It is a key driver to everything that we don't like about our healthcare system. It's the fact that people are coming in way sicker than they should be. And you guys are coming from the spaces in our communities where you're seeing it up close. If you're working in education or if you're working in food access, you're seeing it up close and you know how real those problems are. And what I'm submitting to you is that if you take those same problems and you keep doing the great work that you're doing and you add to that, and here's the health impact, in dollars, in lives, that's a compelling endpoint. That's what we're talking about here. So can we afford to not pursue it? No. This is kind of that value space, right? The value equation is quality over cost is what it means. And we've seen so many studies over the last few years and just calls to say, hey, we need to do more. Adding socioeconomic data to hospital readmissions calculations may produce more useful results. See, when we started to say that we wouldn't pay hospitals if people are readmitted, hospitals started wondering, why are people getting readmitted? If I'm not going to get paid for it, I need to know what happens when they leave my care. And I'm a hospitalist, right? So when I discharge somebody who has congestive heart failure, my first thing is I'm like, I need to get you an appointment, a follow-up appointment within 7 days. Why? Because I know that that's critically important to your ability to do well at home. I also need to know what's your access to food, because I also know that one of the main reasons we see heart failure patients come back is what we usually call dietary noncompliance, which I would say is a function of our retail food environment, right? And so that's a key driver. Your ability to afford the medications that I'm giving you, because if it's new heart failure, I'm putting you on an ACE inhibitor and a beta blocker, and the list goes on and on and on. And I'm like, go buy all these medicines. Go for it. But if you have issues with housing instability and you're already paying 50% of your income on rent, well, paying for those medications after you're feeling better after a couple days in the hospital may not be your priority. And so what we realize is there are so many other things that go into whether or not people get readmitted that we need to look into those. And then when our federal government is telling us you're not going to pay us for it, well, we want to push back a little bit. Before penalizing hospitals, account for the social determinants of health, social risk factors, and equity in Medicare payment. Should Medicare value-based purchasing take social risk into account? What are we doing to our hospitals that are serving more lower-income patients, more indigent patients? What are we doing with these sorts of policies without thinking about those things? The third better question, is what is our approach to doing hard things? What's our approach to doing hard things? My daughter's 7. She took up swimming last summer. I really wanted her to play soccer. I thought it'd be easier. Swimming is any of you have kids who swim? There's a swim parent culture, and it is real. It takes up my full attention when I'm swim dad, like running lane assignments down to the judges. But anyway, she swims during the summer, but this fall she started doing synchronized swimming, which was really cool. So synchronized swimming it's like cheerleading, dancing, and swimming all in one. So really interesting thing. And she had her first synchronized swimming meet 2 weekends ago, and she came to me, and it was the night before, and she was worried, and she was like, I don't know if I'm going to do this routine well. It's really hard. And I have this thing I've been saying to her since she was about 4. And I was like, you can. And she's like, why is that? And I was like, what's your name? And she was like, Avery Webb. And I was like, and what does that mean? And she says, I can do hard things. I've been telling her that since she was a little kid. I can do hard things. Anytime she tells me something hard, I'm like, but who are you? And you can do hard things, right? For all of us in the spaces where we work, we're no stranger to doing hard things. That's the nature of our work in the nonprofit spaces, health systems, whatever it may be. We do hard work. So when I ask, is achieving health equity attainable, your answer should be, it would be really hard, followed by, how do we do hard things? What are some examples in your organization of something that seemed 15 years ago really hard, but that now you're like, but we're the organization that's positioned as we are in our community because we know how to do hard things? And what's your approach? Well, the UVA basketball team knows how to do hard things. The game against Purdue, we were down 3 with a couple seconds left, won that one. Against Auburn, we were down 2 with 1.5 seconds left. We won that one. And then last night, we were down 3 with 12 seconds left. We won that game as well. That's improbable. It is the greatest basketball team ever assembled. I'm going to do this all day, you guys. There's no end to my jubilation. But yeah, how do you do hard things? And so I want to transition a little bit and talk about collective impact, because I think it's an approach to doing hard things, or the kind of hard things that we're talking about today. So collective impact, what do I mean? There's this great review in the Stanford Social Innovation Review on collective impact. This is in 2011 by John Kania and Mark Kramer. And they outline the recipe for collective impact. That's lots of different groups of people who come from different backgrounds, have different fields that they represent, different stakeholders, but they can come together aimed at the same purpose and achieve, have that collective impact. What is it that goes into it? And before this session, I was talking to someone about it, and I said, the thing about collective impact rather, is that it's not that we don't do this already. You guys know how to partner. This is about what are best practices in that partnership when you're really trying to tackle the big things. What are the best practices? They say there are 5 conditions of collective success: having a common agenda, having shared measurement systems, mutually reinforcing activities, continuous communication, and then having backbone support organizations. And I want to talk about those pretty quickly. First, the common agenda. You have to have a shared vision for change. And to put that in this equity framework, if your shared vision, if your goal is health equity, it's pretty broad. If you tighten it up and say we want to address food insecurity because we think that's a big driver for negative health outcomes in our area, that's your shared vision for change. It's to change the retail food environment, or it's to reduce your rates of food insecurity from 17% down to 10% or something along those lines. It includes common understanding of the problem and a joint approach to solving it through agreed upon actions. Having a common understanding of the problem means you have to have conversations. And we'll talk about communication in a little bit, but it means that you have to have a common way of describing the problem as you see it. That doesn't happen out of thin air. That happens through deliberate conversations with lots of different individuals so that you guys can all kind of arrive at that common understanding. That in and of itself is a process. All participants, not some, not most, all participants must agree on the primary goals for the collective impact initiative as a whole. For everybody to be bought in, for every organization to say, this is my work, everyone has to agree on the primary goals. Those are kind of the key components. Next, shared measurement systems. So agreement on the way success will be measured or reported. You gotta know what you're aiming for. So agreement on what success looks like. Collecting data and measuring results consistently on a short list of indicators at the community level. Making sure that you know what are we tracking and how are we disseminating that information? How are we showing people how we're doing? Third, mutually reinforcing activities. This is important. Mutually reinforcing. All participants are not doing the same thing. In fact, if you have a lot of redundancy in a collective impact entity, in a collective impact group, that's the problem. Right? If you guys all do the same work. You want people who do different work than you, or do work in a different way, because you want them to complement your work, right? And so you want participants who are not doing the same thing, and you say, if you think about it, the multiple causes of social problems and the components of their solutions are interdependent. So you want to really leverage the benefit of having a lot of different ways of looking at this problem and having everyone bring their tools into this space. That's the value. You've already agreed that you have a common agenda. You already know what kind of outcomes you're measuring, but you're also saying, hey, listen, I'm going to do it from this angle, from this direction. You're going to do it from that direction. We're all doing it from our vantage points, and that's how we're going to achieve success. Coordination of the differentiated activities through a mutually reinforcing plan of action. So you have to coordinate all those different activities. It's not just you run off in your silo and keep doing your work. It's that now we're doing our work, we're coordinating it. It's different work, but it's pointed in one direction, right? So pretty interesting. That's the mutually reinforcing piece. And the last one is stakeholder efforts fit into an overarching plan, kind of along the same lines. Next, continuous communication, one of my favorite parts. Because people don't like to do this. Because we do meetings, we like meet ourselves to death. But monthly or even biweekly in-person meetings among the organizations. What level? What level? CEO level leaders. Why? Why do we want CEO level leaders being a part of this? Because the reality is, if people at the top of the organization are the ones who are participating in this collaborative, you're showing me it's a priority. That's how I know it's a priority. So that idea of having CEO level leadership at the table regularly changes the game. I'll give you guys an example of this in a little bit. Sorry, I keep coughing in your ears. Meetings supported by external facilitators and follow a structured agenda. As you can imagine, when you bring a lot of different people together with different perspectives who typically work in different spaces, you run into that whole who's leading it, how are we doing it, or this is how I usually do things. And that gets a little uncomfortable, rubs people the wrong way. One of the great solutions is having external facilitators. Somebody who comes in and says, hey, my job is to run this meeting, lift all of your voices, make sure you're all being heard, and make sure that our approach to this common agenda is part of all of your minds, all of your thought processes. So it's a key component. And allow participants to build up enough experience with each other to recognize and appreciate the common motivation behind their different efforts. It also allows them to know that their own interests will be treated fairly. It's important. And the decisions will be made on the basis of objective evidence and the best possible solution to the problem. That's always going to be one of the things that can just derail a collective impact approach, is people feeling like my voice isn't being heard or I'm not being treated fairly. Okay? And so when we're talking about kind of what's our approach to doing hard things and we're saying it's collective impact, it also means that we're saying we're going to truly, genuinely value the voices of all these partners who belong at the table. So if your organization is the one that thinks, hey, I know how to do this well, I don't know about my partners, I should be leading it, it's already the wrong attitude. Because you pick them as a partner because they know how to do something well. You need to lift their voices, you need to make sure they're a key part of the conversation. The last one is backbone support organizations, and this is one that it's kind of it's a dealer's choice. So you can develop a separate organization with a staff and a very specific skill set to address this initiative. So you can do it with a brand new entity, or you can do it with an existing entity. Having a brand new entity, it allows participating organizations to focus their energy on their own missions, and also puts the responsibility for coordinating with somebody else. Sometimes if you have an organization who's a participant also serving as the backbone, it tilts that power structure so that there's not that fairness, there's not that everyone's voice is equally valued. So it's another thing to keep in mind. And then they also plan, manage, and support the initiative through ongoing facilitation, technology, comm support, the data collection piece, right? The things that, particularly for smaller nonprofit organizations, you're like, I don't have the time or the resources to do this, and that's where a backbone support organization is so key. So that's kind of the collective impact model. And what I'm gonna do over the next couple of minutes is talk to you about, as the slide says, Cameron's travels. What I've seen around the country kind of along these lines. I've been around a long time. I'm like really old. And it's not nice to laugh at me when I say that. Gosh. So Cameron's travels, I'm gonna talk to you guys a little bit about where I've been, what I've seen, and how it fits into this concept a little bit. And we'll start in North Carolina, where I went to medical school. And that's Winston-Salem, North Carolina. We recognized in my first year of med school that there was a huge issue with access to care in our community. It was rooted, to be honest, in a history of racism and segregation in this town. Winston-Salem was a very segregated town, even still. It was one of those towns where the other side of the tracks was literally a racial divide of who lived where. And more importantly, the health system, Baptist Hospital as it was called, had a really negative relationship with the African American community in particular, just historically. I'll talk about that more a little bit later on, but what we realized was that sometimes you can't just keep telling people, no, come to us, you should trust us, we're your option. Sometimes you have to go to people. And so in my first year of med school, we founded a student-run clinic where we actually took care across the other side of that train tracks. We planted a clinic. And it was really successful. At this point, the clinic has been around for 10 years, and it does a lot. There's specialty clinics there. There's free lab work, free medications, referrals for social services. This is all started from a student initiative. But this came about by talking to community-based organizations and saying, from where you sit, what do you see the health challenges are? One thing that we learned was that health literacy was a huge health challenge. And one of the other projects that's connected to this was we partnered with the school system. We selected a cohort of students to be kind of like health literacy leaders. And we trained them on key topics in healthcare so that they could talk to grandma, so they can talk to mom about diabetes and management and those sorts of things. We were trying to change the culture of healthcare engagement in our community. So this was called Delivering Equal Access to Care. And just in the fall, that's my daughter Avery. I went back because the clinic is now 10 years old. It's served thousands of patients. And it's just incredible to see the impact that it's had. And I would submit that that's all because of the partnerships that we maintained in the community to feed the health system that I would say was relatively unaware of why people weren't going to seek care there. Now, the health system now, after a decade of this clinic, decided to move the clinic from the other side of the train tracks to this fancy new downtown building. And they said, yeah, because we don't want to make sure that, we don't want those patients to be getting their care over there. We want to kind of bring them back into the mothership. And when they gave me the mic, if you guys can't tell, I don't have any problem speaking my mind. When they gave me the mic at this 10th anniversary gala, I was just like, great event, guys. You're doing the wrong thing. And the reason I said that is that you don't have any reason to believe that people feel safer today coming here than they did 10 years ago. Unless you can tell me that, then I don't trust you. And you still have to be willing to say, do we go back if we lose patients, if we start having folks who say, I'm not willing to make my way across. So there's a health equity issue that we were trying to address. It was access to care, that's in health and healthcare. It was people's comfort with the healthcare system and the approachability of our healthcare system. That was the focus of this initiative. And I would say that the jury's still out. I think that it's interesting as time plays out, you have to stay vigilant because people forget why we started the things that we're doing. People lose sight of it so easily. So I give you this example just so you can see there are a lot of different opportunities where people will think they're doing the right thing and moving in the right direction, and we'll see how it goes. But that's my first experience. Next, we'll move to Chicago, Illinois. That's where I went to law school. And in Chicago, I worked on something called the Health Justice Project. I was expanding from just thinking about healthcare as, or thinking about health equity, I should say, as that healthcare related issue. Instead, I wanted to look at it from that broader milieu of social challenges. The Health Justice Project was started in my second year of law school, and I was one of the first students to work in the clinic. And it was a partnership with the family medicine clinic. So we were lawyers. I had to put my hat on. I was like, I'm a lawyer now. We were lawyers working with doctors. And what the doctors did is they would screen for social needs, and then they would pass the patients to us if they identified any. And specifically, it was social needs in these areas. IHEAL was the acronym we used, but it's income assistance and insurance, housing and tenant rights, education, advocacy and appeals, and legal referrals, IHEAL. Because the thing is, we had legal strategies to address all of those problems. And so from the clinic standpoint, we were strictly value add. We show up, we help their patients navigate more effectively. Raise your hand if you guys have heard of a medical legal partnership or an MLP model. So it's a key, I would say a key component to strong community-based work. There are so many solutions. I had a woman who was a client of mine who had diabetes, and she was getting supplemental nutrition assistance benefits or food stamps. But unfortunately, the amount of her food stamps, she ran out every month, and you could watch her blood sugars. When she checked her blood sugars every single day, they would be fine until a certain point in the month, and then they would be high. And then the next month, they would be fine till a certain point in the month, and then they would be high. And so eventually her doctors were like, because at first they were looking at it over the course of 3 months with the hemoglobin A1C test, but then when they started looking at those daily glucometer readings, they said, what's happening to you on the 21st of every month? And she said, I run out of my food stamps, and so I'm not eating the way that you want me to eat. So what did we do? Well, we applied for an extension of her benefits. We got her extra food stamp dollars, and we solved the problem. Her blood sugar control was flat. This wasn't a matter of of patient adherence or non-compliance. This was structural, functional, and fixable. So keep that in mind. If you haven't heard of it before, medical legal partnerships, it's a really good model, really propagating all over the country and works well. Next, we'll go to New York City. That's where I did my residency training at Cornell. And while I was there, at that point, I'd finished medical school, I'd finished law school, and I told myself in residency, it's really important for me to find a way to stay connected to this. I'm not gonna have just wasted those 3 years of law school. I gotta stay connected in the work. And luck would have it, the New York City Department of Health, they launched something called the New York City Center for Health Equity. And they had a bunch of money, and they were like, we're gonna start this Center for Health Equity. And I just shot over an email, and I was like, hi, I'm Cameron. I'm a doctor, lawyer, and I wanna help. And they were like, okay, yeah, okay, that's fine. And so I didn't know what I was gonna do at first, but their flagship effort was in Harlem, and it was around housing. I had no experience in housing. And so we sat down and we talked to residents of 5 different public housing units, and we learned from them, well, what are the health issues that you're running into? One lady in particular, just to tell the story, she'd had 10 asthma exacerbations in the first 4 months of the year. 10. Her doctors kept saying, you're not taking your inhalers. Why are you not taking your inhalers? You wouldn't have these exacerbations if you were taking your inhalers. You can tell from the slide that I'm putting up what's going on here. We went to her house. I see this on the wall. I see this by the fridge. I know exactly why she has asthma exacerbations, because where she lives makes her sick. Where she lived made her sick. We learned that, and then, the really incredible thing about it was we told her, where you live is making you sick. Let's move you out of here. We can get you into a new unit by tomorrow. She said, no, because I have mobility issues, and it took me 6 years to get this first floor apartment. I can't go anywhere. Again, these are the challenges that patients across this country are facing. So when she's stuck with, do I want to climb 2 flights of stairs, or every single day, every time I come into my house, or just go to the hospital every couple of weeks, I'm going to go to the hospital every couple of weeks, but I like where I am. We were able to do both. We were able to get her out of her apartment, to get it cleaned, into a temporary apartment, and then get her back into her apartment shortly thereafter. Again, this was through partnerships across the community. We used legal services, and at that point I wasn't on the legal side of things. We used public housing, so we partnered well, with public housing. I was in this instance representing local government, right, the New York City Health and Mental Hygiene. But there were so many key partners who were part of this conversation, and what was unique about the Harlem Health Advocacy Program, Partners Program, is that we had leadership in each of the houses. And so residents would go to the housing leadership on health, and they'd say, here are my health issues with our housing. And that's how they would kind of sound the alarm, something was going on. Interestingly, another note for you all who do community work, we were trying to pay people to be community health workers. I don't know if you guys have ever had this experience, but we wanted to just give them money. We were like, hey, we want you to be a part of this. Here's some money. And people were not willing to do it for money. They said, we'll do it for free, but not for money. And the reason is that it impacted their public benefits if they had more money. Now, there's probably part of you that's just like, wouldn't you prefer more money to public benefits? The answer is they're actually making the right economic call. It was against their best interest to get the couple of dollars we were throwing their way because of the outsized impact it would have on their benefits. That's an impossible decision for Americans all over this country. To say that I can't do little things that are going to get me additional income because I'm absolutely dependent on the services and supports that I have. Those are the kind of challenges that we're facing, but I think just being in this space and observing it, it changes the way we have these conversations. And I had a lot of conversations in the Trump administration with folks about that because I think there was this sense of this welfare state or this space where people are just receiving public benefits, and how do we get them away from that? How do we mobilize people, get people working, and get them off of public benefits? And I think it added some granularity to that conversation. It's not just that some people want to stay on public benefits. It's that the way the system is designed, some people are trapped. And how do we work around the traps, right? And so that was a really interesting set of conversations that we're able to have if we have that firsthand experience. So that's New York City. Not all apartments in New York look like that, I promise. And then we'll go to Washington, D.C. And that's where I went after residency. And I was actually living in Baltimore, commuting into D.C. every day. This is when I met with President Obama as a White House fellow. It's a one-year program for mid-career folks to work at the highest levels of government. And it was a tremendous experience because I came in the summer of 2016, and I got to work with the Obama administration. And I'll tell you, they were incredibly experienced in government. They had spent 8 years at that point, 7.5 years, running the country. So they knew how to use that machinery of government to do things, whether you agree with what they did or whether you don't. They knew how to use the space. They were very, very skilled. And I learned a ton. I was working on healthcare, but I was also working on the president's My Brother's Keeper initiative. Raise your hand if you've ever heard of My Brother's Keeper. That's brand recognition. That's awesome. So My Brother's Keeper was President Obama's program to improve life outcomes for boys and young men of color. The idea was that there are certain points in life where boys and young men of color were getting derailed and not achieving the same life outcomes. And some of them, a lot of them, are structural in nature. So if we just work to remove some of the impediments, we'll see better life outcomes. And because I worked on that, you see, we were best friends. And we had a lot of conversations about that. I remember actually this week, I saw President Obama 4 times that week about My Brother's Keeper. It was something he was really passionate about, really, really interested in working on. And this is kind of MBK. These are the folks who were his mentees. He actually spent time with these high schoolers from Washington, D.C. regularly. The young man in the front in the red sweatshirt, he was a C-D student in Washington, D.C. until President Obama started mentoring him. He's actually, I talked to him recently, he's the president of several student organizations at Morehouse down in Atlanta. He's a student leader, doing amazingly, and just a leader in the community. And that's what mentorship does for young people. I think that's what was so profound about it. And I can tell you a similar story about a lot of these young men. Just having somebody tell them, you know, you're valuable, you can achieve at a high level, had a huge impact. And, you know, at this point, again, I had finished medical school, law school, and in residency. And I remember one day I was in the Oval Office with President Obama, and I was about to walk out, and he turns and he walks over to me, and he said, "I just want to tell you I'm proud of you." And I was like, I've accomplished a lot of things, but I'm going to cry. Right? And it just reminded me the power of somebody speaking that kind of positivity into your life is huge. And it made me think, I need to do more of that with the youth in our community. I really need to be engaged and just remind them what they're capable of, because that matters. Those kind of statements matter. So for MBK, 6 milestones: getting a healthy start and entering school ready to learn. That's the first. Reading at grade level by 3rd grade. Graduating from high school, ready for college and career. Completing post-secondary education or training. Successfully entering the workforce, keeping kids on track, and giving them second chances. Now, I bring these all up, and I see my time is ticking away, so I'm gonna talk a little faster, but I bring these up because this was the biggest collective impact strategy I've ever worked on. If you're looking at this list, you see exactly how many sectors. It was 23 federal offices and agencies who I worked with. That's at the federal level. So my work was working with over 150 communities that were implementing these programs. This was community-based in every single state across the country. And so working with them to figure out, what are you doing for these different milestones? You don't have to do them all, but what have you identified are your challenges? Who are you convening? How can we be helpful? How can we propagate strategies that are working all over the country? It was an enormous collective impact strategy. And I think that's why it was effective. When the Trump administration came in, I was like, "Hi, I'm Cameron. I work on healthcare and My Brother's Keeper." And they were like, Don't want you working on healthcare anymore because we're going to repeal and replace the ACA. Ha! And then they also said, we do want you to keep working on My Brother's Keeper. That's a good program. We're not going to call it that, but that's a good program. How many of you are surprised about that? They were very much so in favor of this notion of improving life outcomes for boys and young men of color. And so I think I tell that story because, one, no matter where you are from a political ideology standpoint, you should recognize that life outcomes for youth are nonpartisan. Everybody wants to see people do well. Everybody wants to see young people do well. And so that's where we recognize there was a huge opportunity politically to move this forward. And you may have seen recently there was some work out of the Trump administration around criminal justice reform and second chances and that sort of thing. Again, this is nonpartisan work. And when you put a collective impact strategy behind it, there are people who can recognize some of the value. I'm not saying everything translated from the Obama administration to the Trump administration, but there certainly were some parts where the conversation was open and we were able to have it. Next, we'll move to Charlottesville, Virginia. Oh, look at that. I don't know how that slide got there, but that's Charlottesville, home of the champions. And before it was the home of the champions, this is a place where I have one of my offices. This is called the West Complex at UVA Hospital. It was the original hospital, and this is early 1960s. This was actually a ward where the black patients were in the basement with rats, and there was a draft always. This is where they gave birth and where they were not allowed upstairs. Received really substandard care in the 1960s. This is a community right down the street called Vinegar Hill that was decimated. It was a thriving black community. Residents were pushed out and made way for what is now a Staples and a parking lot. And so this is the legacy of UVA. And that's all tied to this, the events of August 2017. The reality is that there were a lot of racial issues in Charlottesville long before the events of August 2017, but they all kind of came to a head in a different way when people are marching with torches, chanting really unreasonable things, and there's a lot of unrest, and ultimately somebody was killed. This is a really hard time for our community, but the other thing it did is it really elevated community voice in a new way. And people said, we need to speak our truth and our experience. And when you talk about this health system and you tell me that it's open to me and I should be able to come in and receive the care that I need, I'm gonna tell you that my mother was in that ward at the bottom, and we will never trust your health system. Because all we know is how you treated my mother and my grandmother, and we know that I would rather die at home than go to UVA. That's a direct quote from some members of our community. And so when I got to UVA in the wake of all these events in August 2017, and hearing this rhetoric or this reality from our community, we said, well, how do we change that? What's the process of reconciliation look like? We have a new university president, and in much too small a font, he asked for us to convene a university working group on the community. They came up with 4 recommendations. Work on jobs and wages. It's the largest employer in the area, and as of last month, they now, for the first time, pay a living wage to all our employees, right? So that's a start. Affordable workforce housing. Affordable housing is not something that I want to breeze past because it's a huge challenge in our community, particularly for people who work at UVA even, to be able to afford housing to come to work. Public and equitable health care, and this is a project that I'm leading called the Equity Coalition at UVA, where we're measuring for the first time the disparities in our health system. We're measuring social determinants of health, and we're tying that all together, ultimately with some engagement in the community to connect with community partners. And then also youth education was the last one. So there's a lot of work. I'm gonna go pretty quickly. When I say Cameron's favorites, it's some places that I haven't spent as much time, but I love the program, so I'll breeze past them. This first one's in Buffalo. It's called Push Buffalo, and it's People United for Sustainable Housing. They do great work around, particularly on the west side of Buffalo, clearing out old and dilapidated houses, fixing them up so people can remain in place, can come back in, and can live without being sick. That mold issue, different things like that. They've done great work in this community. So the social determinants they address: employment, housing, physical environment, and social environment. They're partners. Government agencies, housing, energy, parks, local elected officials, nonprofits, private sector businesses. And they're looking at just the number of redevelopers who are coming in to kind of change these houses. That's how they're measuring kind of their outcomes and participation. Next, in Oakland, California, a program that I absolutely love, it's called Mandela Marketplace. And it's incredible because it's a partnership between really the local farmers, between local businesses. It's changing the retail food environment in a way that gets everybody involved and benefits everybody. So it's a really awesome program. You guys should take a look at it, but addresses employment, income and wealth, physical environment, social environment. Partners are local businesses who either buy from or partner with the marketplace, educational institutions, youth development, housing, government, foundations. And they distribute a ton of food. Well, it's actually a ton, right? Pretty close. And they produce, and they're addressing food insecurity. And that's what they're doing, and there are a lot of partnerships there. And then finally, I'll point out one, Minneapolis. I'm sorry, it's just where the game was last night, so it's Minneapolis, sorry about that. So Blueprint for Action, it's preventing youth violence in Minneapolis. This is actually initiated by the mayor's office. They were the convener, brought together all the stakeholders, and they said, this is a public health issue in our community, how can we work on it? So they're addressing education, employment, health systems and services, physical environment, public safety, social environment, transportation. It's a huge, huge effort. Remember when we were talking about hard things, when we were talking about the size of this problem? But places are doing it. Their partners are city and county departments, local school districts, local youth agencies, faith-based organizations, local businesses. And they had a 62% in youth gunshot victims, 34% reduction in youth victims of crime, 76% reduction in youth arrests with a gun. And this was pretty early on. So really incredible outcomes. And it comes from the size and the scope of their partnerships. And I think one of the things I love about it is the interaction with law enforcement. We've had over the last few years just some really challenging issues in communities when you talk about police-involved shootings and just all the unrest we've seen across our country. And a big component of this is engaging the community and the police department, getting people to know each other. Our officers all over this country are doing amazing work, and they're doing it, some of the hardest work in any of our communities. And I think a big component of bridging that gap is just people knowing their officers knowing their communities, and people getting to know each other. And they help facilitate that in a major way, right? So it's really awesome work that they're doing there. So I'll end just pretty quickly with moving forward together. What does that look like? So here in Idaho, it looks like learn, lean, and lead. Learn the needs of the community, as we've been discussing. Learn the areas of excellence of your potential partners. Know who does what and who does it really well. That's critical to being able to partner in this space, is knowing who's doing the work in your community. Learn the innovative approaches other communities are using. I've given you a few examples, and they weren't specifically examples where health systems are leading the work, but they're examples where health is at the heart of all work. So it doesn't matter who's leading. What matters is that we're partnering, we're working together. Learn as you go. Iterate. You won't get it right the first time. That doesn't mean that it's wrong. That Harlem Health Advocacy Partners program, we learned we were doing it completely wrong. 6 months in, we had the wrong approach. We stopped, we reset, we started again, and now it's thriving. Be comfortable iterating. In terms of lean on the diversity of perspectives within your organization, right? It takes all of those different perspectives to give you the right idea. That's the power of diversity. It's the business argument. Organizations that have diversity do better because they think around problems in creative ways. So lean on that diversity of perspectives within your organization. Lean on novel partners and strange bedfellows. People who you don't normally work with, but who just might be that secret sauce, that secret ingredient that helps you accomplish your goal, because they're really good at what they do. Think about how you can be creative in identifying your partners. Lean on the growing body of literature to support your work. Data helps. And there's a growing amount of data in all of these social determinants of health that help feed into your work. So definitely keep an eye on that and use it. And lead. Lead from behind. Followership is as important as leadership. As an organization, put your ego aside and recognize that, hey, I can be really effective in this space, this education space, as a health system. I can be really effective if I don't try to frame it all as a health issue. If I say this is a people issue, and these education leaders are doing great work, and how can we follow you? Followership is as important as leadership. Lead into uncharted territory. You have to be willing to take risks. You're not going to have the kind of gains that you want, the kind of impact that you want. You're not going to fix outsized problems with yesterday's solutions. So you have to take risks. Take smart risks. Do the work. But you have to take risks. Lead across traditional boundaries. There are spaces where we're used to working, but how do you operate in new spaces? Again, health system, how can you work in an education space? How can you be a leader for and with them, right? And finally, lead by listening. You're never going to find the solutions if you're talking all the time. Growing up, my mom said, God gave me 2 ears, 1 mouth, so I should listen twice as much as I talk. I have not done that the last hour. But the idea is, how do we listen effectively and use that as a form of leadership? Keep that in mind. How do we lead like UVA? I really appreciate you all's attention and engagement throughout this session. I really think from all the side conversations I've had, all the energy in the room earlier, and all of your attentiveness today, I think that you guys have really a great opportunity to continue to do the great work that you're doing and to do it with new, strong, and unique partnerships. So I wish you the best, and I'll be hanging out with you for the next couple hours, but thanks so much.